This conference will now be recorded.
All right, so I guess that's my cue to start. So one of the articles that I read is this article is helicopter really faster than ambulance, the Padua Helicopter Emergency Medical Service Station Experience. So the clinical question that they were trying to answer is helicopter transport actually faster than ground transport? A lot of times, we're questioning whether the patient, coming from a scene or between different hospitals, whether is it easier to just send them by ambulance or should we get the air squad ready and get them going? So this is what they tried to evaluate in this study. So the PICO questions, the population in this study, where they did 115 transports between 2018 and 2019 in the Veneto region of Italy. 56% of these were acute transports, 43 were back transports, so basically patients that had already received their specialty or higher level care, and they were going back to the hospital that they originally came from for less acute care, and then 1% were hyper specialized. There was no specific exclusion criteria. Um, Technically, the intervention in this was transport by helicopter, and then they compared these 150 transports, transport by ground. And since these patients didn't actually get transported by ground, they used Google Maps to um, kind of estimate how long it would have taken by ground. So the primary outcome that they had was helicopter versus ambulance traveling time, and then a helicopter versus ambulance mission time. Mission time was basically from the start where they decided that they were going to intervene and have transport the patient by helicopter to the time that the mission was done and the patient arrived uh, for their after the objective was completed. The conclusion that the author had was that helicopter transfer or travel does not necessarily reduce the overall transit time for patients. And for shorter transports, what they came up with was less than 59 kilometers should not be used. So this was a retrospective observational study. Um, and so the first question was, a clearly focused issue here was addressed. There was a clear goal here was flight or ground going to be faster for patients, and they had known travel distances. So, it was a very clearly focused issue. Um, and the methods to answer their questions. They had physicians use time clock management. So they basically started a stopwatch from the moment they decided to use flight travel to when the patient arrived and was completely unloaded off the aircraft. Basically, the clock was running during this time. The only slight problem for the ground transport, this was using Google Maps. They weren't able to account for any, weather delays or traffic delays. So this was just using basic, if there's no like best case scenario for ground transport. And all of the cases within the 1 year period were recruited. So, this was an appropriate cohort. They were looking back. Obviously, retrospective observational is not the best, but that was the best data that they had. They used the best data that they could to minimize bias because they had physicians that were involved in the study clocking themselves. And then they were using Google Maps, which is a standardized method for ground transport. They did take into account the confounding factors to why air transport might be a little bit longer, such as the dispatch time, patient prep, and takeoff and landing. However, they were not able to necessarily attribute for ground transport any weather delays or traffic. They did not come up with a method to account for that in this study. Um, there was not necessarily follow up of the subjects because this is a retrospective observational study. Um, the results are relatively precise because they had physicians clock keeping themselves and they were on top of that. And then they were able to use a standardized algorithm of the ground transport using Google Maps. And I believe the results that they had, the results applied to the local population within this sector of Italy. And I think that this does kind of match up with other evidence of ground versus air transport that's available, showing that shorter distances it might be better to just use ground transport relative to air transport because of the other difficulties that come with packaging a patient for flight, takeoff, and landing as well. So some of the key tables and figures that they had in this study, this was figure one. This basically just showed from this epicenter of, flights for that the patients were taken on. It just kind of just shows that there was relatively shorter flights, and then they had occasional longer ones. I think the longest one was like 260 kilometers. Uh, so one of the key uh, tables here, this was basically the frequency of the helicopter route length. So most of them are in this basically 0 to an hour. With the average time being an hour and 26, the shortest was 36 minutes, and the longest being over 3.5 hours. But most were between this 45 minutes and 2 hours. Um, and then this bottom one is the total mission time, which I alluded to earlier. So the top one is just basically, from takeoff to landing, whereas the bottom is how long were these patients from the time that they made a decision to send the patient by air versus, the entire mission in its entirety. So then comparing this from ground versus air, what they found was that, let me just So obviously, as the distance gets longer and longer, the time will increase. Um, I'm just trying to remember exactly which one this is. And then, oh yeah. So these two tables kind of go hand in hand, as it just shows that the longer the distance, the longer it's going to take. And then from here, the difference in times between air and ground for the shorter distances is not necessarily that much different. Whereas once you get to that further distance, when they were using that cutoff of about 200 kilometers, there's a clear difference here. I mean, it's almost an hour and a half difference. Whereas here you're talking about 15 minutes to an hour maybe, and for the cost of using an air ambulance, it might not necessarily be worth it. And then this also shows here, this is the overall mission time, which is orange, and then for helicopters, and then the blue is for ground transport, which, for the shorter distances, the time is relatively unchanged for the overall mission time. And, it just goes to show for these shorter distances, it's not necessarily worth it to use an air ambulance instead of a ground uh, truck, except in these longer distances over 200 kilometers, there's a clear difference in this orange and blue dot here. And there's also, it should be noted that, the coefficient for the air mission time is 0.05, so there's almost no relation. So as you can see in some of these shorter distances, depending on the day, it could be 30 minutes or it could have been 3.5 hours. So that's also a very inconsistent time frame. Whereas, if you have a critical patient and you want to get them there, you don't know, is today going to be the day that it takes 3 hours, or is today going to be the day that it takes 30 minutes? Whereas for ground transport, you have a more consistent basis of it, with a coefficient of 0.94, it's almost completely linear and you know what you're going to get. Um, so for this paper affecting my care and what would I tell my patient? I think for shorter distances under 200 kilometers, it's best to stick with ground transport, especially if you're not expecting poor weather. But then again, with poor weather, air transport might be compromised. But I think that, for distances less than 200 kilometers, it is best to just use ground transport for cost sake. There's also, less resources that need to be used. And I also think it could potentially be safer for the patient too. Instead of packaging them up and you don't know about potential complications in air. Whereas if you have complications when you are on ground, you could stop at a local facility on your way to the, tertiary care center. Um, so I think that all of these risks and benefits would have to be discussed with the patient. And I think basically, if I'm transferring a patient less than 200 kilometers or about 100 miles, I would stick with ground transport. Does anyone have anything to add?
Can you just remind me again what they compared? It was they brought uh they were transporting a patient by ground or by helicopter from one hospital to another hospital, and there was no variation. Is that correct?
Yes.
So the big limitation I would have to say with this study to compare it to what we do is, you know, you can, yes, that's very predictable and it's a good subset of data, but at least for most EMS providers, the decision to request a helicopter is, prolonged extrication and where are they going as secondary care. Now, if you say time zero for between an ambulance and a helicopter is, the same because of your extrication time, that helicopter can make it to a trauma center a lot faster theoretically than a ground transport. Um, or that ground transport will have to transport to the closest facility with a helipad and then transfer to a helicopter and then go on to another care center. So that's something to consider when looking at the study, that you're looking at the same distance, the same, time zero and time, destination. It's not necessarily as applicable to our patients.
Okay.
The other
Was
question that I have with looking at this is, did they give any reference to the nature of the roadways? Was this a lot of local roadways or highway roadways? Because that could also impact your travel time. So travel on a highway is going to go much faster versus local roadways where it may be the same distance and take twice as long.
So they did not allude to exactly what roadways were going to be used. They just said that they used Google Maps and that they noticed that a limitation was going to be that they didn't account for time of day, traffic patterns, which I guess you could count, for highways and local roadways, as they're not accounting for that because of the traffic patterns. They said that they did not account for that, and that could be a potential limitation in this study.
were these scene calls for the helicopter or truly interfacility transports?
So it says here that they were interfacility transports, that they were for acute care, back transports are just for hyperspecialty. So they were from one facility to another.
So that one of the issues we experience here in New Jersey with this is not just the travel time, but the availability of the SCTUs to do these transfers. And that seems to truly influence why the helicopters get used as much as they do here for less than the 100 miles or 200 kilometers. Primarily because the SCTUs are either not available or coming from such a far distance, then the helicopter becomes a viable option.
Yeah, one of the things we also have to watch out for, especially with these research papers, is that, our what I always say is, are these patients like our patients? So a lot of the times, if we're thinking about doing an interfacility transfer, traffic is a huge thing in New Jersey. So if I have to transfer someone that's going to pass through the shore traffic, I'm more likely to use a helicopter than go by ground. But in the off season, ground is going to be much faster. So that's one of the limitations, is not thinking about the traffic patterns as well. And sometimes, like if you're on the beach and you can see the hospital, to go through some of the bridges and some of the roadways, it'll take you 2 hours versus the 15 minutes by air.
Hi, good afternoon, guys. I also have one thing to add in. Steve and Neil pointed out very well. If they're using Google Maps or some sort of mapping system, they're assuming that that interfacility transfer unit itself, the SCTU or the ambulance, is stationed right there at that location. So I think from a system design, it's hard to extrapolate something that's theoretical. Like there's a SCTU sitting outside of every single facility, and that's the reflex time. Whereas you have a distributed model like in New Jersey, you're out across 12 or 15 different facilities, sometimes even out of state. So that's availability is different.
Absolutely. And everyone who's worked a transport truck knows, or a hybrid where you're a transport and a 911 truck, you get dispatched to do a transfer, and on the way, something drops and you get diverted to the call. And that's why a lot of times with our transfer system, we give ranges like, oh, they'll be there like between 2 and 3. And then sometimes it's 4. Anyone else want to say anything? I mean, I'll just close it off by saying that, using the helicopter is definitely a very big thing that helps us with our patients. It makes a big difference. I wouldn't really change any of my practice based on this one paper because it's also very specific for that area. I think as a system, you can look at New Jersey as a whole and basically replicate this study fairly easily. But it's definitely something that we can look at.
One of the things that I think for me, as far as practice is concerned, 200
Gary, you're really, really low. Can you speak up?
200 kilometers is a pretty far distance. I mean, and so, to determine whether I want to fly someone, honestly, I think I'm still going to go back to the basics. Is this patient critical? Does this patient need a time interval intervention? So whether it's a cath, whether it's a neurosurgical intervention that needs to take place on this patient, and what's the necessity of actually transporting my patient? And then looking secondarily at, is my patient stable enough to, tolerate a 2-hour drive? So that, poses all these questions because, putting your crew, to go, 120 miles, lights and sirens may not be the best option either versus going by air, where you're going to basically take a flight trajectory and that's it. So I think looking at, what exposure you have to your crew, whether you need to actually get somewhere lights and sirens, and then secondarily, the intervention itself that needs to take place and the hemodynamic stability of your patient, I think all that has to take place and into consideration when you're determining whether or not you're going to fly someone. Certainly, shorter distances are a lot easier to consider and make a decision on, but when you're talking about these lengthy kind of flights, I mean, I think, personally, 200 kilometers is a very long distance. I think that I would think twice about that. That's all.
All right, shall we move on to the next article if no one else has anything to say about this? I'm guessing Steph is SMP.
That's me.
1 second. Let's make you into the presenter.
Okay, can everyone see my screen?
Yes.
All right, cool. Hi, everybody. I am Stephanie. I'm one of the PGY2s at Northwest Israel as well, also on EMS this month. So basically, my article was the drivers of increasing emergency ambulance demand. And basically, the clinical question that they were trying to answer are what are the factors driving increased emergency ambulance demand? So just to, I guess, like give a little bit of background. So this article was basically regarding a retrospective observational study. It was done in Australia from 2008 to 2015. And so basically, in terms of the population, they were looking at all ambulance attendance by Ambulance Victoria in Melbourne, Australia from 2008 to 2015. Ambulance Victoria was like their paramedic unit. So basically, any call where a paramedic arrived on scene, whether or not there was an intervention, that I guess like case was recorded as part of the study. They did not include any inter-hospital transports or retrievals, no pre-booked non-emergency transports, or any cases referred to alternative health facilities via secondary triage, or anything after 2015, there was like some sort of change in like their emergency medical protocol after 2015. So they only record 2008 to 2015. There wasn't really, I mean, like, I guess if you want to say an intervention, it was basically, you know, like, I mean, there was really no intervention. It was just, was the paramedic on scene? Was the case recorded? Basically, for the most part, they recorded. They compared all of the years between 2008 and 2015. However, they're mostly looking at, like 2008 versus 2015. And basically the outcome and the author's conclusions were that there was an increase between this time period, ambulance demand, and it did exceed the population growth. And they were being used for transport of patients who didn't actually require any intervention from the paramedics. And so we'll get a little bit more into that with the graphs towards the end. So in terms of the quality checklist, so did this study address a clearly focused issue? Yes. Did the authors use an appropriate method to answer their questions? Yes, they did. So this Victoria ambulance service, they did have this like electronic patient care record, much like we use in the States. And so that's where they were getting their cases from. I mean, cohort wasn't really recruited. They kind of just, like went through the EMR and just gathered the information that they needed. Was the exposure accurately measured to minimize bias? Yes. Was the outcome accurately measured to minimize bias? Yes. Again, it was all basically just like data collection, and they excluded the things that we mentioned before. Have the authors identified all important confounding factors? They did. There was not really any follow-up. The results were precise. I do believe the results, and I do think that it was actually a pretty interesting study. Can the results be applied to like our local population? I think that they can. And do the results of this study fit with other available evidence? Not really sure. I didn't really get a chance to like look at a bunch of different articles regarding this specific topic, especially because it's like a topic that's new to me. But I think maybe everybody else will have something to say afterwards. So in terms of what they actually found, so the first figure here is basically showing the age-adjusted incidence of ambulance cases. And basically what they found here was that in 2008, there were 66.6 cases per 1,000 person year. And then that increased to 72.7 in 2015. And basically what they found again was that the demand was increasing more than the population was actually increasing in this specific area. In terms of the second table, so the second table was basically just showing like the age-specific incidence rates, and the incidence was highest among patients that were over 80 years old, and I think this was kind of just like a thing that they already knew. This was like a finding that they already knew, that like older patients were more likely to call for an ambulance. But the other thing that they noticed was that the incidence in patients aged 60 and over didn't really change it during that period that the study was conducted, but it did increase in patients who were less than 19, 20 to 39, and 40 to 59. So basically anybody under 60, they realized that there was actually like an increase in the amount that they were like using, that those age groups were using the ambulance. So this second table basically was just looking at, figure 2 was basically just looking at like the growth according to the patient's characteristics. Oh, hold on, I'm sorry, I skipped a table now, so I was confused. So table 2 was basically just looking at patient characteristics. And so basically what they noticed was that most of the patients that were recorded in this study that were calling, like calling an ambulance and paramedics were coming on the scene, greater than 50% of them actually had no pre-existing medical conditions. And they noticed that there was an increase in calls for mental health, as well as like mental health, like emergencies, as well as alcohol and drug related emergencies. And then, so for figure 2, again, this is with the growth according to these characteristics. So like, as mentioned before, kind of consistent with, like the previous table, that alcohol, drugs, mental health, those were all, those calls, patients with those characteristics all increased in terms of like ambulance demand, as well as younger age groups, and those of lower education and socioeconomic status. Which was also pretty interesting, and I do think pertains to our patient population. Table 3 was basically looking at clinical characteristics of the ambulance cases. And again, I don't mean to be redundant, but basically, again, it was an increase. They saw from 2008 to 2015, they saw an increase in overdoses, alcohol-related cases, psych calls, as well as infection, sepsis, and pain. And then the last figure on here basically was trying to show the annual growth in ambulance use according to the clinical characteristics. And again, they saw like increase in drugs, alcohol, pain-related calls, and they actually saw a decrease in like calls where the paramedics actually had to perform some sort of intervention in these groups. So basically overall, I guess like the takeaways from the study was that they showed the increase in, like, again, like drugs, infection, alcohol-related, psych-related, pain-related, as well as like younger age groups calling for an ambulance. And then overall, most of the calls where the paramedics appeared on scene, there was usually they saw an increase in no intervention versus, like the patient requiring intervention from the paramedics. So basically applying this to my patient care, as well as, applying it to, like Newark and New Jersey in general, I think that our patients definitely need to be educated on, like when it is appropriate to call, like to call EMS for transport. I think that some patients are not educated to the point where they realize what, like what needs to be seen, like immediately versus, like what they can, call their primary care physician regarding. So I think that the other problem, obviously, in Newark specifically, is that a lot of patients don't have primary care physicians. And so, after educating that patient who has, come via, EMS, who might not have had to, helping them establish care, giving them information regarding how to set up an appointment with a PMD, I think is like is actually like crucial, as well as kind of like, like giving education to them regarding any sort of like myths. I think that there's like a very common misconception that if you arrive via an ambulance, you're more likely to get seen faster, which at least at NBI, it's not really the case. Like the charge nurse will have no problem sending a completely stable patient, who comes via EMS to the waiting room to wait just like everybody else. And so kind of just like explaining all those things to them. That way they can make more like educated decisions. And that's all I've got.
Yeah, I remember when I used to work as a paramedic, I would call the charge nurse on my cell phone and drop people off at the regular entrance, not even come in through the ambulance entrance. Sometimes one of the things, especially when you're talking about public policy, trying to reduce your ambulance volume is kind of counterintuitive, because depending on your pay structure, you may get paid by the calls, not even by the patient themselves, but they look at your call volume. So do you really want to decrease your volume? And then on a public policy standpoint, do you want to take that risk of telling people, oh, you shouldn't have calls, and then now they have a stroke, but last time they came in, you told them not to call, so this time they didn't call, and now they have all these issues because they didn't come in for their stroke or for their heart attack. So those are some of the things that you have to think about going down the line.
Yeah, absolutely. I think that I think that information can definitely be misconstrued if not explained properly.
Exactly. Anybody else want to chime in?
Yeah, if I could. Hi, everyone, again. The question is, this is a Victoria, correct? So they have a slightly different model of their paramedic services, correct?
Yes, I believe so.
Right. And so one of the questions is, and you alluded it.
And so I think that for every, go ahead.
What you alluded to was actually the transport destination, being the cause of the bill. We look at EP3 and the new options for reimbursements and pilot projects, but really at the end of the game is, if we have identified mental health as the issue, then why are they still going to the ER? Or why are they even filling the ER if they're not in an acute situation and there could be an alternate pathway for that? So if anything, this is just, I think, more fodder for the cannon to say, we need to look at our system and find those alternate transport destinations, obviously working with medical control, getting clearance, and sort of adapt our system, because I'm sure Australia has the same thing. They don't have enough mental health beds available for everybody, so they languish in your ER, clogging up the works. So I think maybe that's just another point to go forward, but sometimes be more cognizant of the system-wide issue than just the paramedic arriving at the patient side.
You bring up a very good point with the more community paramedicine that I never thought I would see it in my lifetime or my career, because I always, we were always, in the past, we always got paid by transport. If you didn't transport the patient, you didn't get paid. Then we were able to start billing for RMAs. Then slowly but surely, we were able to bill for more and more things. And it seems like the payers are now looking at quality of care versus just, oh, we're just going to pay you to transport the patient. That's it.
Sure. Has there been any data or anything coming out of what Cooper was doing with the buprenorphine and alternate pathways for the overdoses?
I have not heard anything about it yet. I think COVID kind of messed up a bunch of their study and what was going on over there, but I'm sure it's going to pick up, and they're definitely looking to publish something on that experience.
Yeah, sorry. Just from my personal experience for the past 20 years or so, at least in the collegiate environment within Rutgers, we've always had this alternate pathway of having folks in crisis not go to the ER if they were medically sound, but going over directly into the crisis intervention center, APS, over in Piscataway. And I just always wondered why in 20 years we have not seen a growth of that to help that crisis intervention service and not clog up the ER.
So,
I mean, I can't speak for Piscataway, but one of the things is that it's one of those issues where it's someone else's problem, and the people who are paying for those resources may not be keen to, contribute funds to take care of someone else's problem.
the other key thing to remember with this study is, being that it was done in Australia, it is all of their paramedics have bachelor's degrees in paramedicine. So they do have that additional training, and I think that's why they're a little further ahead of us in making their alternative destination decisions. So it would be beautiful to see that here, but obviously we're a far way off from that. As far as the Cooper study, I know Matt McGuire's on the call, and he was instrumental in putting that together. So I don't know if he can maybe update us a little on it.
Yeah, I worked on the Cooper project. It was one of my babies when I was there. COVID kind of threw it for a loop, but it was tough dealing with the opiate crisis because you had such a fluctuation. Whereas one day you might have 10 patients, the next day you have 0 patients. And it really the funding stream seemed to be one of the biggest problems. Like, how are you getting reimbursed on this, and how can you keep it going? That was really what the biggest problem was. Is once you run out of grant funding for it, how do you actually keep the program alive?
I mean, the $1 million answer is advocating and legislating and getting that changed, obviously, and finding inroads into under things like SAMHSA or other grant programs that allow you to expand. And as Steve alluded to, the scope has to be at the edge of your practice where you can actually make the impact and show them that, yes, for a few $100s, we can help you do this. And that's what it comes down to.
Yeah, so when we're talking about increases of volume for EMS, you know, does what they see make sense in our system? Like, you know, do we see the same trends that more and more people are calling 911, or do we not? A lot of people on this call, you know, they've been doing EMS longer than I have. You know, what have you seen?
From a New Jersey centric issue, I think one of the things that we have seen is as institutional settings have decreased, bed availability in either inpatient or psychiatric hospitals and or facilities that had patient populations that were very, for all intents and purposes, segregated to that facility, they are now living in the community. So that's pushing the onus on that medical care no longer to a nurse that had 5 or 6 patients, but now in a residential style facility that's embedded in a municipality. And now the municipalities are picking up that up as a BLS assignment, and then ultimately ALS is seeing that as a hospital. So the mental health side, I think, has always been there. They're just not centralized in a facility. They are now spread out across all the areas, from urban to suburban to even rural. There's outpatient residential facilities, I guess, inpatient residential community groups or group homes that they're living in that now become the municipality's burden for 911 calls.
That's very true. And then especially nowadays with COVID, you know, what type of mental health issues are coming up because of that? And we're not going to know until it hits us.
No, you make a great point. Someone that was making progress on an inpatient or a high, I forget now, it's like a highly compressed schedule. You know, they're seeing 2, 3, 4 times a week, high intensity counseling, versus someone now who's relegated to home and maybe gets a 45-minute Zoom conference once a week. How does that shift, or how do those folks become a bigger challenge for the mental health system?
I also wonder if the telehealth actually will improve some of these people, because maybe what they need is that regimen, that seeing someone even by Zoom or something like that, or GoToMeeting, if that's going to make a difference.
So that's a little bit of a sticky wicket, and I don't mean to corrupt your presentation on this one, but you start to talk about diversity and equity and access to things. We also make the assumption that the folks that are truly in need of mental health have automatically access to smartphones and Wi-Fi and stable connections and even a place to make this phone call, right? So that's one of the questions about, do they actually have the technology to do that, or are we seeing a divergence, and now you're getting folks who don't have access to it, who really are the mainstay that they were getting maybe a county helped drive to the inpatient or outpatient facility. Now that's gone because of COVID. Now they're at home. They don't have a stable internet connection. They can't get out of the house to even get to the local McDonald's or Starbucks or whatever free Wi-Fi they were using. So are we going to see a divergence or a split really between them?
No, I've definitely seen some of that, and some of the public health policies. I've seen they've also included sending people home with telehealth services where they set up Wi-Fi for them in their home. But it all depends. It's a local kind of level decision on who's going to spend the money on that or grant dollars.
There's a short-term program at the state level to open access, I think, among the major carriers, Comcast and Verizon, to open in the urban areas, to open Wi-Fi specifically for telehealth purposes, open those ports and leave them open for about 60 days. I don't know if anyone has heard whether that got extended or it's just sort of faded off by the wayside, or if anyone has any import or impact from that.
I know that Verizon had active, free hotspots for anybody who had a smartphone to try to help support that, but that got discontinued last month after like 4 months. So I have a feeling it's probably in that same bucket there, Les.
All right. I think we're closing up with Dr. Lin.
Yep, you want to transfer access over? Okay, got it. Let's see. One sec.
So for those of you who don't know, Dr. Lin is actually one of our EMS fellows. He comes to us from the emergency medicine residency at Newark as well. And we'll let him get started.
Although we're trying to change this to presenter mode.
If you hit F5, that might do it.
Okay. All right, so Dr. Lin, you call me Brian. I'm MD 479 at Newark, and then Rahway, I'm 620. The paper I chose was this one. It's titled Intra-Arrest Transesophageal Echocardiographic Findings and Resuscitation Outcomes. It was actually published in 2020, so this year in July. It was done in Korea. So the reason why I actually chose this because as technology improves, as things become more compact and more available to everybody, things like a TEE, which ER doctors probably never imagined doing in the past, it's becoming more accessible for us. MD1 obviously has a TEE, and we're still learning how to use it, as well as how to incorporate it into our cardiac arrest. But even things like video laryngoscopy once was only available to anesthesia, ICU, and ER. Now it's trickling down to EMS systems, so it's becoming more widely available. So let's just go through this article. This is actually a observational study, so these are some of the questions we'll try to hit. Though some of the questions are obviously not as applicable. So what is a TEE? So for those of you guys who don't know, it's basically an ultrasound that goes through the mouth down into the esophagus, and actually provides some very good images. For those that work in the ER, of course, when you're doing an echo during a cardiac arrest, the structures that are most close to you are going to be your right ventricle, left ventricle. Whereas with a TEE, what's closest to you is actually the left atrium and the posterior part of the heart. So I thought that was pretty cool. Just show you guys some images as far as what you might be able to see with a TEE. Really, the purpose of an echo in cardiac arrest is to give you an idea of what might be happening, especially early on in the cardiac arrest. You're looking at the heart, the great vessels. You're trying to figure out some kind of underlying reason as far as why they went into cardiac arrest, right? And while we're doing this, we're at least in the ER, we're doing this during the pulse checks, looking at the contractility and seeing if it's adequate for a cardiac output, right?
And of course, this should never interfere with your compression. So like I mentioned, we're always doing this during our pulse checks. Contrary to, transthoracic echo, a TE can be done, without any kind of interruption of chest compressions, which is why this is more intriguing. This purpose of this article was basically to determine the echo findings in intra-arrest and patient outcomes. That was the first question. Did the study address the clear focus? Yes. The second question is actually, did the authors use an appropriate method to answer the question? Yes, I believe so. It's a retrospective observational study, as I mentioned before. So going down, so how was the cohort recruited, and was it in an acceptable way? I would say a little bit no. Explain why further in a little bit, but when we actually look at the patients, there was about 1,000 patients from 2017 to 2020. They excluded all patients who were under 20. And then they also excluded patients who were in cardiac arrest from non-medical etiologies. So things like drowning, trauma, hanging. And you can see in the top right box, there are 475 patients excluded, 317 of which were dead on arrival. And then there were 158 with non-medical etiologies. So the drownings, trauma, things of that nature. So out of the cardiac arrests, the eligible patients were of the N of 576, and of those 576, a large number of them, 325, were not did not have the TE performed because there were no personnel available. Some of which, the 76 had ROS, so they didn't have a TE done, and then some were DNR, so they didn't have the TE performed. So of this 1,000 patients, in 3 years, only 158 actually got their TE. So who actually got the TE? So as mentioned before, if you look above, so 325 did not have TEs done because there was no physician available to actually do the TE. So that kind of changes the amount of patients that are that qualify for the study. The ER doctors who actually performed the TEs actually had over 150 hours of TTEs, so transthoracic echo examinations. They actually completed like a test that was, I guess, proctored by other ER doctors as well as a cardiologist. So this is trying to standardize their interpretations of echoes. And they were also tested on their TE skills on live patients. The other part of this is, who didn't get a TE or who, gets a TE is the patients who actually had ROS prior to 10 minutes in the ED never got a TE. So only those patients who were arresting in the ED for longer than 10 minutes actually had a TE performed. And obviously that actually lends to some bias as well. You can see the ER doctor coming in with the TE, and that might actually change the outcome of the arrest or the efforts of the cardiac arrest, resuscitation. Next, these are some of the images that they're showing. As you can see, they're super clear. As you get closer to the heart with any kind of echo, your images are a lot more clear and you're able to see a lot better as far as the structures go. And then, like I mentioned, of course, the structure that's closest to you is going to be the left atrium, whereas when you do a transthoracic echo, the closest structures are the ventricles, right ventricle, left ventricle. So what are they actually looking for? They're looking for specific and non-specific findings. Specifically, for cardiac arrest causes, they're looking for aortic dissection, so basically a flap in the aorta. They're looking for tamponade, specifically a large pericardial effusion with right ventricular collapse during diastole. They're also looking for PE. In some cases, at least when I've worked in the ED, we're always looking for RB dilation and RA dilation, but they were actually looking for actual clots, thrombi in the RB, RA, and pulmonary artery, which is more, the pulmonary artery at least is more visible in the TE than a transthoracic echo. They were also looking at sequelae of cardiac arrest, so thrombi or echogenic densities in the left atrium and left ventricle, just sequelae of just blood stasis. So there could be thrombi in the heart as well. Non-specific findings like valve changes, dilated aorta, small pericardial effusions, hypertrophy, that kind of stuff. If you actually look at through the patients that were in this study, so there were 40 patients who actually got the TE. I'm sorry, so there were 40 patients with TE positive and 118 patients with TE negative findings. And if you look at kind of both parties, they're very similar. Their comorbidities are similar. But when you compare it to the patients we work on in Newark, I mean, almost everybody over 50 or 60 is going to have hypertension, plus or minus diabetes, and maybe hyperlipidemia. That's kind of the triad where we work, at least in Newark. And this population seems to be a little bit healthier, but of course the patients are all from Korea. When you look at the other characteristics, there's actually a significance between T negative and T positive group as far as VFib goes. With the first monitor rhythm, T negative group actually had a significant amount of VFib patients versus the T positive group, which had none. Otherwise, the rest of these characteristics are very similar. All right, one sec. So back to the findings on TE. Specifically, this 40 patients had positive TE findings. We discussed what they were before: dissection, PE, tamponade, and then thrombi. Those are the numbers. When you actually look at, if you're actually looking at like how believable these results are, these ER doctors were standardized. They all had testing done as far as how to identify structural differences from live patients. They had a cardiologist actually test them. I think the results are pretty precise. I think it'd be pretty easy to see an aortic dissection with a TE, given how clear the images are. As far as the PE goes, if you can actually physically see clot in the pulmonary artery, ventricles, and atrium, I think that's that would be more specific, and I think that would believe the results. As far as cardiac tamponade goes, I also think that's within our skill set. We should be able to find that. Moving on to the next slide, we're looking at outcomes in this slide. So the outcomes were largely the same, whether you had a T positive or T negative echo done. Survival to discharge was pretty much dismal for both groups. But I think this largely goes down to the T positive findings, whether it's tamponade, massive PE, or aortic dissection. If you have those findings and you're in arrest, likeliness of having ROSC is actually very low. And in addition, some of these patients are actually arrested for more than 20 minutes. If you actually go back and look at the BLS duration, ACLS duration, both these patients, it's 20 plus minutes, right? And we also mentioned that only patients that had longer than 10 minutes of arrest in the ED even qualified for a TE. So these are, the sickest of the sick, and the outcomes are obviously not going to be great for either group, whether or not they have positive or negative TE findings. With that being said, we'll go on to the discussion about, what is TE actually useful. For the TE, in their opinion, was most useful for structural problems, right? Not functional aspects. And when they talk about structural aspects, they're looking for defects in the anatomy of the great vessels and the heart. So, pericardial effusion. They're looking at, tamponade. They're looking at dissection and PEs. Another study they actually mentioned was this other study of 48 patients with out-of-hospital cardiac arrest and in-hospital cardiac arrest with TEs done. They included PEs, tamponade, papillary muscle ruptures, aortic dissection, but they actually also added MI. And 50% of those patients, of those 48, actually were attributed to an MI. And it's interesting because they were able to detect a wall motion abnormality during intra-arrest, which I don't even know if it's even possible to do, especially with CPR going on. You're probably causing trauma. Besides getting rib fractures, you can have small pericardial effusions, pleural effusions. You can probably cause cardiac contusion as well, which could contribute to wall motion abnormalities, I'd imagine. So, I mean, for this study, I think it was worthwhile to do. I think it's interesting. I think as technology gets better, things become cheaper. We'll be able to use it for different reasons and purposes. I would like to see a study done where they actually use this from, as soon as the person gets the ED or even, and out of hospital. I wonder if that would actually change the outcomes, because like I said, in this patient population, 20 minutes of ALS care or BLS care, cardiac arrest in greater than 10 minutes, the chances of coming back are very low. And so these are the sick of the sick, and the outcomes between positive and negative TE findings, it's probably not going to change your numbers very much. And so I'd like to see that done as far as getting a TE done, TE performed on a cardiac arrest patient sooner, just because it might actually change the outcome of that patient. With that being said, I'll open up the floor. If anyone has any questions, concerns, or would like to mention something, I think this would be a good time.
They didn't happen to
All right, I
mention
can.
like find VFib or anything, did they? Because I've heard of some studies done in America where, like, in the department they've used it and they were able to see that it was actually like a find VFib rather than asystole.
So they didn't actually mention that, but I think it would be interesting to have that, like, a study done on that to see what, first of all, if VFib is seen on echo, if I don't think some of these TEs can actually defib, but it'd be interesting to see if that's even more efficacious than doing defibrillation using the standard pads and whatnot. But no, they didn't actually mention that in the study. They were just looking at structural abnormalities and the rest of the table that I showed before, not specific and specific findings.
Hey, Brian, I think it's a good article to kind of go over. One thing, particularly, I think, looking at structural abnormalities and PE and stuff, and I think I agree with you, like waiting that long to do any type of resuscitation when you have an advanced tool is kind of moot. And even when you look at, interventions, you would want to do those types of interventions early on. Even, let's say we talk about giving TPA in a cardiac arrest in someone who has a PE, a relative contraindication is ongoing CPR greater than 10 minutes. So, that's one thing that you kind of look at that takes it out of the scope. Another thing I would have been interested in seeing really would be, actually looking at chest compressions. The whole purpose of like doing TE during a cardiac arrest and like actually during active CPR is that you actually have a live view of the actual heart, and you can actually look at the ventricles and look at contractility of the ventricles with chest compressions. We know that the heart itself, doing compressions over the sternum is something that we've kind of made to make it very easy for, laymen to kind of, provide CPR. But in reality, we know that there's heart displacement, whether it's COPD, CHF, persistent hypertension with cardiomegaly, and so that the heart can be displaced to a certain degree. And so the, mid-sternum may not be the appropriate place. And many a times, I've done active resuscitations where we actually have to move laterally to do chest compressions to where you actually see appropriate, actually ventricular contraction and actually forward flow of blood when you do chest compression. So, I would have loved to see maybe utilization of TEE early on in resuscitation guided care for chest compressions and looking at contractility of the ventricle during active CPR, especially when patients are coming in initially. That's going to help, save patients sooner than anything else. Looking at, determining whether someone's in 5 VFib versus, asystole, anecdotally, Frank, I'll say, I've done, now tons of ultrasound and cardiac arrest. And one thing I've noticed is that when you have a patient who initially goes into a VFib arrest, no matter what you see on the rhythm strip, whether it's VFib, coarse VFib, or fine VFib, the heart initially has a very robust fibrillation, and you actually see the heart fibrillating. And then, when you do a round of CPR and you do another pulse check 2 to 3 minutes later, the fibrillation, the rhythm strip may be the same, but the fibrillation is not so robust. And you actually see the heart dying every 2 to 3 minutes, and you see the fibrillation get less and less and less. So I say that, 20 minutes in, if you see this little fibrillation of like a twitch of a heart or even just a fine VFib, at that point, in my eyes, that heart is now pretty much, dead. And when I've seen this happen time and time again, is the time to intervene, the time to, really convert that underlying rhythm is really initially. And that's why we always go back to kind of our basics, early defibrillation, and that's kind of where, our mantra should be, is like kind of, how do we convert these patients who are actually in persistent VFib? And, the sooner we convert them, the better. Patients who come in, and, this is always a challenge as well, like patients are in persistent VFib. Do we pronounce those patients? Well, I can tell you anecdotally, looking at the heart, yeah, I mean, at a certain point in time, you're going to have to. But these are the challenging cases. But I think looking at a TEE, being able to assess the heart, looking at, actually what the heart's doing during active CPR, that's a huge part of resuscitation. And I think that it could have been really implemented in this study.
Hey guys, something else that I think should be considered is that the ability to see structural heart disease dissections, things that require a different intervention, from a pre-hospital standpoint, also offers you the option of changing your transport destination. If you're going to a hospital that does not have cardiac surgery, maybe you shouldn't. Maybe you should go to the other hospital that does have cardiac surgery. So again, looking pretty far forward, we're still trying to trot this out in the hospitals, let alone in the pre-hospital environment, although certainly, we do have one and we're using it. But looking at changing your care in some of these things that are harder to diagnose, there's been discussions about pushing TPA as well, in pulmonary embolism, if you can see the large clot, saddle embolus, etc. So there are some real changes in the management of these patients. Obviously, it has to happen early on in the resuscitation for you to be able to see differences in outcome. I think it's valuable that you're realizing what it is you're dealing with and making the appropriate diagnosis, but obviously there's a time critical element of that as well. And I think that will change a little bit relative to the technology improving. There's still some issues with that.
I think this just brings home the fact that a lot of our stuff that we do
has to do with that we don't know a lot about cardiac arrest. And that's why, like, early defibrillation with the double sequence project that we were working on, and also this with the TEE, the same thing. Tagore, you're trying to talk?
Oh, no, I'm good.
Does anyone else want to say anything? Tagore, I think we have feedback from you. That's what it is. Does anyone else have anything else they want to say?
Yeah, I think so. Les wrote a comment in the chat room saying that I guess in pre-hospital care, handheld ultrasound would be, a good use for ALS during resuscitation. And I think that kind of goes along with this in a sense that, like, as things become, more affordable, more compact, things will trickle down. And, someday I wouldn't be surprised if ALS had ultrasounds available to help guide them in their resuscitation. Maybe not a TE, someday, maybe 20 years from now, but at least a handheld, ultrasound for transthoracic might be, something that's in the near future for them. I mean, the butterfly is already here, but, they have to make it more affordable in order for more people to, invest in them.
There are already a lot of institutions and EMS agencies actually that do have ultrasound on their ALS rigs across the nation. And a lot of HAMS units actually have ultrasound as well. So it is something that's actually progressive. There's been lots of studies about, the learning curve for paramedics with point of care ultrasound, looking at asystole versus VFib versus tamponade, or large pericardial effusion, and even looking at lung sliding. So there is a lot of potential in this, and there's a lot of institutions that already have been utilizing this. And certainly, I think there's huge value in doing point of care ultrasound. I think one of the things that we bring to the table, I always stress, I can't stress this enough, is that one of the things that I always use ultrasound routinely in the emergency department is always going to be the cardiac arrest patient. And again, what changes your management? If you have a huge pericardial tamponade or pericardial effusion, and you see that patient early on in your resuscitation, you're packaging that patient and you're moving that patient to definitive care because they need an intervention that you can't take care of in the field. And that's kind of your H&T. Versus, you actually seeing that, say, yep, there's no pericardial tamponade, we're going to stay in play. But additionally, looking at the ability to be able to do point of care ultrasound and actually, manage your patient appropriately is huge. Cardiac arrest is one. The undifferentiated shortness of breath, that's another one. It's so vital that we target patients' shortness of breath and their tachypnea and their respiratory distress to what they're coming for. And how many times have we seen the patient who's got the COPD, CHF, and we throw basically both kitchen sinks at them, saying we're going to treat both of them and see how they do. And I mean, we've done that for years, and I'm not saying there's anything wrong with that, but at the same token, if we can target them, we can do a point of care ultrasound, look at B lines, and we say, yep, this is CHF. I'm going to target this as CHF and treat them accordingly. That's patient-focused, patient-centered care. And, time and time again, it's the trauma, it's the CHF, it's the shortness of breath, it's the cardiac arrest. That's where the ultrasound is king, and that's where it really wins. And I think that it's a valuable tool in the pre-hospital arena.
All right, I think that's all for today. Thank you for everyone joining. We're going to be doing this almost every 4 to 5 weeks, roughly every 4 weeks. And I'll post on Facebook, and I will work on getting this recorded on the YouTube channel as well. All right, thank you very much.